good afternoon. Feel free to put your cameras on as well, because I think the group is not too big, so that might make it a little bit more interactive as well, as we can try, because I think we're around with 9 people. So let's see. Yeah, again, thanks Judy for the introduction. I thought I should start with a small introduction of myself, as you're wondering, who is this lady and doctor from Utrecht presenting on the topic on malnutrition in low middle income countries. And I think already most of it was already in the introduction, which was going around by Judy as well. So I'm trained in the Netherlands, have been focusing on pathology in sub-Saharan Africa, and did a PhD in HIV, mainly containing care in Malawi, and worked from 2018 to 2021 for the Global Hope program, Texas Children Baylor College of Medicine in Lilongwe, Malawi. And this was focused on hematology and oncology. And since 2021, I'm back in the Netherlands, which is my home country, working in the Princess Maxima Center, where I'm part of our global outreach program, where we are focusing on collaborations in Kenya, Malawi, Tanzania, Kosovo, and Indonesia. And a big part of my focus for my research is on malnutrition. And as well, from September off, I will join Judy as co-chair for the SIOP nutrition work group on this topic. So that about me. So let's go back to the topic. And I really hope this topic, we're not really a very big group, but I think all are very experienced in the problem of malnutrition with cancer in our countries, in low middle income countries. So a lot of the things I think I'm sharing might not be totally new, but I really hope it can be a step up for discussion as well, and a focus of our group, where to focus on and how to focus on together. So I think at the end, if we have some time left, I would like to see if we can have some discussion as well on the issues I think I'm going to raise. But besides that, I really hope from what you can take from this lecture or this talk is that malnutrition, in my opinion, is really a key in the treatment for children with cancer in low middle income countries. And we should also realize that this is a big thing and might be the biggest difference for treating children with cancer if you compare to high income countries, which means also the knowledge for this topic is not in the countries on high income, but it's in the countries where most of you work. And I think that's really good to realize. The other 3 points, what I hope you take on, is that malnutrition is not restricted to age, and especially not just restricted to children under the age of 5. We'll talk about that more. And I think cancer treatment and nutritional support should go hand in hand and cannot be separated, especially in these countries. And challenges on nutritional support, and I will touch base on that, are not just in your local setting, but might be regional and national, and might be even international. And that's why I think we come as a group in as well to talk together how we can improve this kind of practices. So just in general, because I didn't know who was there in the audience, but this for most of you it's totally clear. Malnutrition is an issue. And worldwide, nearly half of the deaths in the under 5 are attributed to a nutritional issue or to undernutrition, which is massive. And if I'm going to talk in this talk about malnutrition, I will talk about malnutrition in general. So I will not differentiate between marasmus or kwashiorkor. And if I talk about severe or moderate, I will separate them. Otherwise, I take the group from moderate and severe as one group, just to make it clear what we're talking about. The identification of malnutrition, just as an introduction, as I said, most of you, I don't think this is new. What do we need? The basics we need is weight, height, and a mid-upper arm circumference. And of course, there's way more you can do. But in most of our settings, especially in low-income countries, this is what we can do. And then weight for age, weight for height Z scores and weight for age are mostly used for the kids under 5. And above 5, we use the BMI. Then if we talk about MUAC, this is mainly focused, or was before focused for the kids under 5. And I think when I talk to a lot of colleagues, also my colleagues in Kenya, for example, they still use it for mainly the smaller kids. But more and more, we're going to use it for the kids above 5 as well. And I'll come back on that a little bit more later, why that's also so important for kids with cancer. But what we need to realize is that the MUAC Z score in children above 5 is less studied. It is recently validated for mortality. So in that sense, there's working and progress on it. And it's nowadays also implemented in the WHO integrated management for adolescents and adult illnesses. And later on, I will show you the recommendation from SIOP, where we integrated recommendation on MUAC above kids in above 5 years of age as well. And recently there was a study published also for members from SIOP, where there's a reference curve for mid-upper arm conference for assessments for under and overnutrition in school-age children in India, which I think shows there's really work in process on this topic, but good to realize that using the MUAC for kids above 5 is less studied than using it for under the age of 5, but not a reason not to use it. And later on, I will touch base on that a little bit more. This, as again, just for the folks who don't know it, WHO guidelines, and this is from the adolescents, where you see you can use MUAC above the age of 5 as well. And then, as almost the last bit of the introduction, how do we treat children with malnutrition in low middle income countries? We have the WHO products, which is the F75, F100, RTF, and of course in places where you have more resources, you might have other nutritional supplies, maybe even NGT feeds. But I think if we really look to the low income countries, then this is what's available. And I think what is good to realize is that this is developed for what I showed in the second picture. The mortality ranges for kids under 5 are highly related to undernutrition, or undernutrition is a big part of that. And that's why these products are developed for kids under the age of 5. So then take it more broadly, before we go really to pediatric cancer, we need to realize, if we look to the effects of malnutrition, that it's really affecting the whole body. And we know that when we treat children with SAM or MAM, that, you know, it's not just the belly or the lungs, but it goes from cardiac function, it goes to the skin integrity, it goes to the development of the brain, it goes to your immune system. Literally every part of the body is involved when you have moderate to severe malnutrition. And that's good to realize when we talk more about childhood cancer. So now taking it up to childhood cancer. So if we look to childhood cancer, what about childhood cancer and nutrition? And well, here, so we're in this group, I think we're all very familiar with that, but I think we have to realize we have 2 problems. It's the overnutrition and it's the undernutrition. And for this talk, we of course will focus on the undernutrition mostly. And we need to realize, why is that energy balance not in balance anymore? And I think there's 3 big parts of that. It's the needs, the losses, and the degrees of intake. Why do you have more needs? You have cancer, so you have to have, there's more metabolism, and we can have different talks on that. I'm not going into details. There's cytokine release, so you need more needs. But you have also more losses. This can be due to growth of the tumor or to the treatment. As for chemotherapy, you might vomit a lot, or you might have other issues. And on all of that together, there's less intake. And that, of course, goes to an energy deficit for growth. And in the end, when you have severe malnutrition, you go to organ dysfunction, which I showed, I think, in 3 slides back, that malnutrition is really coming into every part of your body. Yeah. And I think over the years, oh, sorry, not everyone is muted. If it's possible to mute, that would be great. Thank you.
Okay, that is, yes, yes. This one? This is another one someone sent me, so I just, like, it has disorders, yeah.
Guys, is it possible to mute? Thank you. Perfect. So over the years, I think different studies indicated that only children with solid tumors have an increased resting energy intake, and that for leukemia, that's more baseline. But I think our kids have different problems with having already a baseline suboptimal nutrition rate when they get cancer. So that in general about, you know, malnutrition and cancer, and you know, what does it do? Where does it come from? And I think that was all quite known to most of you all. When we talk about prevalence of malnutrition, are we talking about a big issue? Or are we talking about a small issue? And it's good to realize. And if you go to literature, lots of literature, especially around 2000, 2010, going back, there's a big review looking to malnutrition. And you see that the rates are a little bit different for leukemia if you compare to neuroblastoma. But to be honest, the rates were never in that review coming above 50%. But if you look to where the studies are coming from, they're mostly coming from high-income countries. And in this systematic review, they included quite a lot of studies, 46 studies, but mostly from Europe and North America, some of South America. And again, you can see that only for neuroblastomas, it went up to 50%, but the rest did not increase over 30%. But is that realistic for what we are facing in low-middle income countries? At least that was not what I felt, and I'll show you our data from Malawi later, when I was working in Malawi. So we went back to the literature and looked what over the last, let's say, decade is published by colleagues from low-middle income countries. And to be honest, that's not massive what you can find on it, but these were the most, what I could find, at least in a rough, quickly search. And there was a study from Trine Israels, our colleague who's working a lot in Malawi as well. Already in 2008, she presented that 55% of her patients presenting in Blantyre, Malawi, were malnourished at presentation. And that contained a lot of non-Hodgkin lymphomas, but also some of the solids and a small rest group. There's a study from 2016 from South Africa, where they published something on Wilms tumors. And based on weight for height and BMI, they saw around 15% wasting. But if they actually looked to MUAC, they went up to almost 2/3 of their population of Wilms tumor patients. There's a poster presentation of colleague Wally et al. In 2018 at SIOP. He presented that in Botswana at presentation, 53% of the kids had moderate or severe malnutrition. There's a good paper from Nicaragua where it's 2/3 based on several markers, but an average 2/3 of the kids with cancer who presented. And you can see it was Wilms tumors, Burkitt's, and AML. So it was really a big group of cancers what they studied. There's a big publication of our colleagues from Brazil, where they showed there was a big difference in all the variety of cancer. They really took all the publications from Brazil together, so that's why I put them in as one. And they studied, pointing that together in that review, more than 2,000 patients. But you can see the range of malnutrition on the patient population became from 10 to 50%. But I think as well, Brazil, of course, has very different sites, very remote sites, but also the sites where there are folks with way better income and better access to food. And then there was a study from India in 2015, where like 1/3 of the kids, up to 40%, with a hematological malignancy presented with malnutrition. So you see, even from our colleagues, what I roughly could get from the literature, it's up to 50–60% in some of the cases, but also cases, especially like, for example, in India, where it's less. So malnutrition in childhood cancer in low-middle income country, I already said a little bit. I think in general, you see the ranges from 10 to 60%, which really ranges over severity depending on region and disease. But I think we have to realize, why is this? And I always say, like, if you have a borderline nutrition status already, and on top of that you get sick, we see that with all the non-communicable diseases, you're way more prone to get malnutrition. So I don't think that on its own is a very strange thing happening. And these are the numbers from 2021 from Malawi, Botswana, Uganda, where you see in the general population there's 3 up to 6% of wasting already for the kids under 5. These numbers always present mostly the kids under 5. So then if we take that in relation to children with cancer, and again, this is just a short talk, but I showed you this picture already. All the parts of the body are involved when you are malnourished. So what does that do when you have cancer as well and you want to start treatment? Because we know when you are malnourished, you have an inadequate growth and development, delayed wound healing. So if you have to do surgery or you have a wound around your tumor, that might be delayed. Impaired cardiac function can be an issue, especially if you want to give anthracyclines or other drugs and you need to, for example, give a lot of fluid together with the treatment. The decreased immune function, risk on infection, and this is pretty big because we know that already with giving chemo you have a decreased immune function, or when you have ALL or any hematological disease, your risk for infection is already high, and on top of that you are malnourished. And we know from several studies from our colleagues that also malnutrition is related to prolonged fever neutropenia, which make these kids pretty at risk when you're going to give him treatment, because you have to get them through more severe and prolonged fever neutropenic periods. And overall, we know that kids who are malnourished have an inferior overall survival. And I think that's still very scattered, coming from the fact that, you have, for example, a decreased immune system, but also from the fact that, the more severe malnourished, you might even have walking longer with your disease and have more severe disease. But I don't think we have all the data yet there to present here that it's a clinic that it's a relevant one-to-one cause. But I think all of us working in the field, we know that this is of course related. So I want to start with a case to come up with some of the issues I think we should handle as a community, or at least think about. So I wanted to talk about John. John is 7-year-old and he's presenting with a swollen abdomen and suspected abdominal mass. He's referred by the Paediatric Oncology department to the nutrition unit. So there's no full diagnosis yet, but that he's malnourished, they don't want your help on that. So he's alert, slightly pale, he looks very wasted. He has a length of 120 centimeters, a weight of 23 kgs, and a MUAC of 10. And I think what you already see, that is especially the MUAC, which is pretty low, especially when you compare it to his weight. But of course, you have this extended mass, which is palpable in the abdomen, and you see an extended belly. And then this boy is 7 years old. And I think that brings us already straight to the problem I raised in the beginning, that for children with malnutrition and cancer, it might be very important to use our MUAC. And I think more and more data is showing us that this is the way to go. And although MUAC is less validated for kids above 5, if you have a big and massive abdominal mass, but you have a MUAC of 10, you are severely malnourished. So this is published by our colleagues and from the group in SIOP as well, where there's a recommendation if you are above 5 and you have a tumor mass, so with a tumor mass, especially tumor mass in the abdomen, I think that MUACs are very good to use, and it's very recommended to use. So this, I think I will really, would really recommend to all of you to have that in practice as well, because I still see also in our sites, for example, in Kenya, that this is not always the practice as we go by the national guidelines, where in Malawi, this was integrated for kids above 5 with some guidelines on MUAC and reference for MUAC as well. But that's not everywhere the case. And sometimes you only have the under 5 malnutrition guidelines with national, not really guidelines for above 5, and then you might miss out on that. But we can discuss on that more when I'm finished with the talk. But I think that's really a point of attention. So let us continue. So John is indeed diagnosed with a large abdominal mass, which seems to be localized in the right kidney. And secondly, he's presenting with 2 large non-noduli. So there's metastatic disease. So again, your physical examination, which is again the same as I just showed you before. So then the question, what are we going to do? So by protocol, you should start with chemotherapy, and I think you all agree. There's a renal mass, and we have to treat with chemotherapy. That's our protocol. So the treatment will be vincristine, doxorubicin, actomycin in most of the places, I think, because we have a metastatic disease. And then is the question, what do we do next? So there are 3 options. I will give nutrition support before I do anything else. Because the boy needs to get stronger before we are able to give him chemo. And secondly, besides nutritional support, I will give the chemotherapy, but I will dose reduce with one third of the dose. Or last, besides nutritional support, I will give the chemotherapy, but I will go for 100%. So what should we do? And is that evidence-based? Sorry again, before I continue, can you please mute when you just joined? Welcome to join. Could you please mute? Thank you. So what do we do? One of these 3 options. And is there any evidence for one of them? I said already, malnutrition is related to impairment of your body on several organs. And especially for chemotherapy, impaired cardiac function can be a big issue. Impaired hepatic function can be an issue. Impaired renal function can be an issue. And impaired immune system and prolonged neutropenia is an issue, as your side effects of your drugs might even be increased. So what do we know about prolonged clearance of your drug? Because if you have an impaired hepatic function and a possible impaired renal function, and your albumin levels are low, is it safe to give chemo? And what do we know about the dose reduction? So if we look to the pharmacokinetics, there's not much on kids with severe malnutrition, the ones you are treating. There's some adult studies who show an association between body composition and chemotherapy, where they show that lower clearance rate in malnourished adults, which means like your drug is longer in the body, you have more toxicity. There's some animal studies as well, which showed altered pharmacokinetics of anthracyclines in malnourished animals. And they showed larger clearance rates and a larger volume of distribution for doxorubicin, for example. And if you look to studies in children, there's limited data and there's a trend towards clearance rate with lower BMI, but there's really lacking data on kids with severe malnutrition because the data is coming from Europe mostly, some studies from the US, where we talk about malnutrition, but that's, that it's the top of the iceberg of the moderate malnourished kids you see in your clinic. And then thirdly, there's lack of pharmacokinetics, genetics in the settings and low middle income countries. And why is it important? For example, the expression of CYP3A5, this is an enzyme which is involved in the clearance rate for vincristine. We know now that clearance rate for vincristine are different in a lot of the Black population due to different expression of these enzymes. And there's still a lot of research going on this topic. But this is important to know because we might think it's because of the malnutrition, because our population is more malnourished. But there might be other issues as well based on the pharmacogenetics and not just the kinetics. So I think if I go back to my question, what should you do? The protocol, the SIOP protocol for Wilms tumor says that you should dose reduce. And I think that's very, very good to do. But to be very clear, there's no clear answer based on the data. And we need to treat the childhood cancer, we need to treat the malnutrition, but we also have to make sure the toxicity is doable for the child. And therefore, I think it's very recommendable to dose reduce. But I think of more importance, we should really aim in our setting in low-income countries to have more data on this topic, to have more knowledge on the importance of safe and effective chemotherapy for these children, which can really contribute, I think, to the overall survival for our kids. So case 2. This is an 8-year-old female presenting with a mass in her abdomen as well. Loss of appetite is 1 to 2 weeks. No night sweats, no medical history. This is her presentation, and what you see as well, again, we have a very malnourished child. And she as well has a very hard masses in her abdomen. And this is an 8-year-old. So besides the chemotherapy, which we just discussed in the other case, and dose reduction, what are we going to do now? She's 8 years, and you are in a low-income country where you have to support her presented, I think, on slide number 5. You have F100, F75, and you have RTF. That's what you have available in your local nutrition clinic. So you get your chart, and you take the chart, for example, for the F75, and what you realize is that this goes up to 10 kgs. So these charts, again, are made for kids under 5. So how do we support these kids above 5? Because they need a lot of the milk compared to the kids under 5. And I think we have to clearly recognize as a community, in my opinion, that we don't have clear guidelines for the places where we really use the WHO recommended nutrition support, and there's nothing else available. And we do the best what we can, but we have to struggle with guidelines were made for kids under 5. And what I said, for example, in Malawi, we did not have any other NDT feeds available besides some of the local porridge, for example. And I started to realize when I was working in Malawi and seeing this issue, are we the only one? And we just looked to our data as well. And we saw that in our population from 2018, 2021, 2/3 of the kids were above 5, which is showed in the graph here. And our mean age was 7.2 years. So this was a big deal, actually, because 2/3 of the kids were not even fitting into the guidelines. But then, of course, you can question, maybe malnutrition is not as common for the kids above 5, and that's why your problem is still not very big. And before I show you our data, I went back to the quick search I did to show you the prevalence of malnutrition, and looked at what our colleagues said about the age of the presentation. And you see the colleagues from Malawi, they said they saw kids with a median age of 7. South Africa, this was a Wilms tumor patient population, so again, that's a bit skewed on that one. Median age of 3.9. Botswana, median age of 6.5. Nicaragua, they said they had a median above 5 years of age with a big range up to 16 years. Brazil did not have a median age, but had included kids from 0 to 18 years, and the same from India. So this is not very hard and a proper done review, but I think it showed already that we were not the only one, and that felt a bit comfortable for me as well. And then we looked in our data, do we have a problem for the kids under 5? And actually, which I did not expect, we had, because severe malnutrition was more common among kids above 5 years of age when compared to the kids under the age of 5. I mean, both groups have an issue, but it's not that the kids above 5 don't have an issue. And they actually, in our setting in Malawi, they had even a bigger issue than the kids under 5. So besides that, we also looked in Malawi in the Lilongwe with my colleagues to the deficits. What do? We have the kids on the ward, we have our local support, and what we had was extra porridge for the kids on the ward, sometimes some local products and some extra milk and eggs. And besides that, and the normal meals, we had the support from the F100, F75 and the RTF, which we were giving, especially the RTF, to at least as much kids as possible. So what did we do? We looked for the kids under the age of 19, which was mainly all the kids in our ward, and we did the nutrition status based on the WHO recommendations, and we calculated the basal metabolic rate and the estimated protein requirements and the estimated fat requirements for the needs they had when they were on the ward. And we're combining that to see what they were actually eating, and if we were coming close to their daily requirements. We evaluated a total of 34 patients, included age was a mean age of 7.5 years, which is, I think, representable what I showed you before. At that time on the ward, we had severe malnourished kids, 24%, and 38% of the kids were moderate malnourished. And in this cohort, we had a big gap on the metabolic rate, on the protein rate, and on the fat. So I think on all the 3 steps, the kids were not having their daily requirements, and only 4 children achieved the requirement caloric intake. So even though we really tried our best and had as most as possible our nutrition guideline in place, with the support we were still having, and we're facing, especially on the fat and the total metabolic, proteins was not too bad, with a gap of 8%, but we're still having a gap of on all the 3 pillars. And that's important. And I think in that same line, I was very happy when I looked at today to some more data on this that Maya, our colleague, which is in our nutrition group as well, just recently published a study where they very nicely in a randomized control phase 3 open label trial gave RTF to their kids on the wards. And to not go into detail, but what they saw on 260 subjects they enrolled, and half of them, of course, got the RTF, and the other ones got the standard protocol. And they saw for the RTF group a weight gain, which was significant. They saw an increase of fat mass, which was significant. And they also showed that the kids who got extra RTF support had fewer episodes of severe infections, had less treatment delays, and less severe mucositis, which I think the 2 of these things combined shows that, yes, I think we're using local support, you're facing a gap. And again, we need way more data on that, not just our small quality improvements project. But I think what Maya presented here is that with support, which is available through the WHO, we can make steps. And I think this study is a really good example for that.